Yeah. Okay. So is it 6? Yeah. All right. We might start. Thanks everyone for joining the webinar. So the webinar is on hospital-acquired infections. And so before I start, I'd like to acknowledge the traditional owners in the country that we are meeting today, and acknowledge the leaders past, present, and future. So I've got Dr. Phil Chia, who is a general surgeon, endocrine surgeon, and trauma surgeon, who will chair the session on webinar. So if you have any questions, I'll encourage you to write it in the on the chat box, and we will take questions at the end. Over to you, Phil.
Thank you, Siva. Good evening, everyone. I can see there's lots of people online, which is great to see. Thank you for joining this evening's ANZASM presentation hosted by the ACTASM. The theme for this evening is sepsis under surveillance, preventing and managing hospital-acquired infections, which I'm sure we all recognise as a significant component and factor in our patients' outcomes. We have a terrific panel of speakers this evening, and I expect it to be engaging and educational as always. As Siva mentioned, putting questions in the... Shall we put questions in the Q&A rather than the chat, Siva, just so we try and get them all in the one spot?
Yep, I'm happy with whatever you like.
So if questions go in the Q&A, that would be helpful, and we can get to those as appropriate. Our first speaker is Dr. Nick Coatsworth. Dr. Coatsworth is an infectious diseases and respiratory physician at the Canberra Hospital, and he's also held many key leadership roles within medicine, including as the Deputy Chief Medical Officer during the COVID pandemic. This evening, he's presenting on post-surgical pneumonia. Nick, I'll throw to you.
Well, thanks very much, Phil, and thank you, colleagues. I'm actually, now that Teams is switched over to PowerPoint, all I can see is my PowerPoint, so you'll have to yell out if something goes wrong with the slides. But look, I'll kick off, and thanks to Siva and surgical colleagues for the invitation. Actually, just by way of background, I'm actually at the acute medical unit at Canberra Health Services at the moment, which is where I've been practicing for the past 2 or 3 years. Originally trained in respiratory and infectious disease medicine, and have been doing more of a generalist role for the past couple of years. So it's nice to be asked to talk about these things, which are much closer to the sort of subspecialty things that I do. Now, we'll talk a little bit about definitions tonight, but the main substance of the talk, I guess, and I hope what the discussion will be in the Q&A is the extent to which we spend time in the church of antimicrobial stewardship, because really the measures that we know work for prevention of ventilator-acquired pneumonia and hospital-associated acquired pneumonia, I should say, are conservative measures that have a solid evidence base. What we really need to try and work out, in my view, is the value of perioperative prophylaxis, and particularly in the ICU, but not exclusively in the ICU setting. I think there's questions around surgical patients who don't have to go to ICU and who are extubated in recovery, and whether there is a role for more antimicrobial prophylaxis to prevent post-surgical pneumonias. It's a question that sometimes I feel might be difficult to bring up if it was an infectious disease audience. But I think when you look at the evidence, there are still questions to be answered there. So just some straightforward definitions to get everybody on the same page. Hospital-acquired pneumonias occur 48 hours after a hospital admission in non-intubated patients. Ventilator-associated pneumonias obviously occur in patients who have had intubation, including those who are post-surgical. We'll look a little bit at the diagnostics and in particular the diagnostic criteria, because importantly the clinical and the research criteria for diagnosis are different, and you do get some vastly different results depending on what definition you actually use for a ventilator-associated pneumonia. But I think, from my perspective in respiratory and infectious diseases, the important thing here is these are distinct clinical and pathophysiological entities from community-acquired pneumonia, and they therefore require both a different treatment and prevention type of lens applied to them. Clearly, we're talking about patients who have been intubated in the large part here when we're talking a surgical patient cohort, and that is the single biggest risk factor for a hospital-acquired pneumonia, with the risk of ventilator-associated pneumonias increasing for each day of ventilation in intensive care. The mechanism is very straightforward mechanically. It's an issue with being supine, risking aspiration of oropharyngeal secretions, often in quite sick patients. The sicker the patient, the more their oropharyngeal and upper GI flora is disrupted, and the more likely you are to get pathogenic gram-negative organisms, which we'll talk about in the subsequent slides. That has led to one of the key interventions in intensive care, which we'll discuss later on, but that is nursing patients in a semi-recumbent position. Of course, the very act of giving people sedation and anaesthesia impairs the ability to the usual physiological mechanisms for sputum clearance and increasing the risk. The deep tendency of our intensive care colleagues not to want to re-intubate people, well, it's because it markedly elevates their VAP risk after they've been extubated. So increasingly, I think most of us who are sitting in their late 40s, early 50s in our career now have seen a tendency towards a number of things in our careers, one of them early extubation, and we'll hear from one of the other speakers the importance of getting people mobilised early and up and about, which a lot of the ICUs and post-surgical wards are obviously doing, and one of the reasons is to prevent this very problem. Then the patient cohort's obviously important. This is where it can get a little bit difficult with the big randomised controlled trials of the interventions to prevent VAPs, which is you're talking to get the numbers to power the studies. You've got quite heterogeneous cohorts. And I had a few discussions with colleagues at the George Institute. Have been doing a lot of the studies on managing VAPs or studying the care bundles to decrease the incidence of VAPs, and that's one of the problems and potentially one of the reasons why they can't get effect sizes in some of their studies. We'll move on to that later. I mean, some of the implications, and this is a figure from the second dot point, which is from the Journal of Thoracic and Cardiovascular Surgery. But I think the issue here is that both hospital and ventilator-acquired pneumonias have a significant increased risk of negative outcomes, and some of them is actually an increased mortality risk. So that Annals of Surgery paper showed quite a marked increased risk of death in the subsequent 90 days in those who had a HAP compared to those who didn't after abdominal surgery. And the cardiothoracic study there showing nearly 17% mortality after 17% of mortality after cardiac surgery was attributable to hospital-acquired infections, of which the two most common in that cohort were Pseudomonas aeruginosa sepsis and HAP. And the Pseudomonas is either coming from their invasive devices and lines or from the HAP itself. So I mean, you don't need any more statistics. You've seen from your clinical practice to see how much of an issue it is. It's not just death, of course, and the endpoint in the studies is important because you also have just a deterioration in the patient's clinical state and inability to return to their previous level of function. So it might not be mortality, but might be a significant impost on their overall function and their morbidity going forward. So some diagnostic elements. I mean, I think practically in the intensive care unit or on surgical wards, when we see fever and unexpectedly elevated post-operative white cell counts, the presence of purulent sputum and tracheal secretions, it is something that we start to worry about early and treat early with broad-spectrum antimicrobials. Obviously, chest X-ray findings and CT infiltrates are helpful to actually confirm the diagnosis. Oftentimes, as we know, we'll treat it empirically without necessarily finding those. I suppose the challenge has often been that the cultures are negative. So you're talking about somewhere between, and it depends on the study, but 40 through to 60% of studies have shown that you don't actually get any growth from gram stains, from sputum cultures, I should say, and the result comes in 48 hours later, which is a little bit too late. But I suppose the fourth dot point there is where I wanted to dwell on this slide, which is there's no single gold standard for the studies. And there was an Australian study in the MJA actually used a 5-item VAP screening checklist. And you see the criteria there: worst gas exchange, sputum change in sputum quality, infiltrates, inflammatory signs, and microbial growth. If you used that, you found a VAP in 17% of ventilated patients in that particular study. Physician judgment only diagnosed 18%, so a similar percentage of patients were diagnosed, but the overlap of patients between the two methods only occurred 17% of the time, and sort of highlights the variability not just in VAP definitions, but the potential for under and overdiagnosis and some of the challenges when it comes to doing like-for-like comparisons with the research out there. Importantly, and this speaks to the sort of difference in the pathophysiology, we're talking about a different microbial cohort here where HAPs and VAPs are gram-negative bacilli, Enterobacteriaceae predominate, so your Klebsiellas, E. coli's, and then more difficult to treat organisms traditionally like Pseudomonas, Enterobacters and Acinetobacters, and depending on your setting, some of the bigger tertiary institutions in the larger cities do have issues with multi-resistant Acinetobacter, and fortunately here in Canberra our multi-resistant patterns are somewhat manageable, which is it's a pretty interesting geographic difference. We don't have a huge amount of MRSA here, whereas 3 hours up the Hume Highway it's a pretty different story. A quick comment then on the PCR rapid-based tests. I think that's an innovation that we've seen sort of take hold in the post-COVID period, where the multi-array PCR, respiratory PCR tests can give you a much quicker diagnosis of an organism present in someone's secretions if they have a VAP. And you can see that the sensitivity and specificity is as expected for a PCR testing, very high, well over 90 and approaching 100%, whereas the sensitivity of culture is much lower. So I think the presence of those rapid PCR tests, the multiplex PCR tests, although we are not using them that much here, offers the possibility of narrowing antimicrobial spectrum, although obviously you're not getting sensitivities off a PCR test. Just in the interest of time, we'll go through this relatively quickly, but what should you be expecting from your infectious diseases physicians? You'll generally see Pseudomonas cover, and piperacillin and tazobactam is the most commonly used antimicrobial. Increasingly, and depending on your hospital, you may get an extra agent in there in terms of an aminoglycoside to cover for multiple gram-negative resistance patterns. And actually, that is US ID Society guidance to have 2 agents. MRSA coverage, if that's your local patterns as well. Another change, and I think across every single ID diagnostic category that I can think of for common infections, we deal with either community or hospital acquired. The trend has been for shorter therapy and a quicker IV to oral shift. So you can expect to see that in the advice that's coming to you regarding your patients with HAPs and VAPs. And of course, we spoke about the Church of Antimicrobial Stewardship. It is a church that I'm part of, and the overall idea is to avoid overuse and avoid the impact on the ecology of your resistance in your hospital. But there are limitations to how far we should push that philosophy, and hopefully there's some questions. I can't see the questions yet, but hopefully there's some questions turning up about that, particularly as we go to the discussion now about how we prevent particularly VAPs in ICU, but these are similar strategies that you can use for your prevention of hospital-acquired pneumonia. But specific to VAPs, these are bundled practices that your intensive care should use, although there is variability. There are studies showing variability in implementation, but here's a few things that you will have seen. Nursing in a semi-recumbent position, oral hygiene with antiseptic solutions, so Chlorhex mouth rinse, maintenance of adequate cuff pressure. Probably the most important is early extubation and getting the patient moving, and then your aseptic technique of your circuit management, all important things. And just to show, if we didn't already know how important this was, but this is quite a lengthy study in Spain, which was occurred in all in 181 ICUs in Spain, so 75% of them. The goal was to reduce VAPs across the entire country, and they used these measures. Now, the first 7 in the bundle I've basically spoken to you about. I just wanted to draw your attention to the last 3 highly recommended, particularly A and C. One's selective digestive decontamination. So that is topical non-absorbable antibiotics, things like colistin and nystatin, and a short course of systemic antibiotics. So this generally means gram-negative cover in the form of something like ceftriaxone. That was part of this bundle, which showed quite a dramatic reduction in VAPs. So you can see they went from 9.83 VAP episodes per 1,000 ventilator days down to 4.34 per 1,000 ventilator days. So just in the last couple of minutes before we take questions, what do we do with peri-procedural antibiotics and HAP? And the problem here, I think, is study heterogeneity, different clinical endpoints, and using different antibiotics, and of course different types of surgery are probably going to lead to different outcomes. These 2 studies just demonstrate what I'm talking about there. So one of these was clean orthopedic surgery, elective orthopedic surgery, and the effect of just continuing standard prophylaxis for longer. So we're talking about a 1st or 2nd generation cephalosporin. I think it was cefamandol in this one, and less than 24 versus 48 hours of prophylaxis showed no difference in hospital-acquired pneumonias. Now that's probably because neither the 1st and 2nd generation cephalosporins aren't intended to make any difference with hospital-acquired pneumonias because they're not covering the organisms. So it doesn't suggesting that we should increase our Kefzol. By contrast, and you can see that's quite an old study in 2008, after lung resection, there was a 45% decrease in postoperative pneumonias if you got 24 hours of amoxiclav instead of kefamandol. So that indicates that if you change the type of prophylaxis and you start prophylaxing the gram negatives, which is the whole idea of selective oral decontamination, that you get better results in prevention. So Australia leads the way in this sort of research. So the meta-analysis by Naomi Hammond of the George Institute, published in the JAMA in 2022, nearly 25,000 patients. If you selectively decontaminated the digestive tract and you gave people a short course of gram-negative cover, you saw a reduction in hospital mortality of 0.9, and largely attributable, I think, to the reduction in hospital-acquired infection there. One of those studies was the Myberg study. So, and this is, of course, the big ICU clinical trials group in Australia. Was a 6,000 person RCT, and you can see the diagram there. That actually wasn't big enough. It was only when you stuck everything into the meta-analysis that you actually saw a difference there. So what does this mean? Well, there is a theory, and I'll close on this because it's the basis of the study. Anthony Delaney from Royal North Shore Hospital and the George Institute is leading this study, was an senior author in both of those studies mentioned there. The current theory is that the selective oral decontamination, the nystatin and the colistin, is not making a difference, and the ceftriaxone is. And so they will be doing a study on ceftriaxone alone, and my understanding is that they're recruiting that now. I'm just going to stop sharing here and close with obviously, as I was having these conversations, the next question I asked to the intensivists up at RNS in Sydney was, well, are you doing any of this? And interestingly, the answer was no. So despite the fact that they've got some data suggesting that it is the right thing to do, it's not, or when I say right thing to do, where it may have an impact on patient mortality, it's not been, as far as I'm aware, systematically implemented in Australia. So I think that's an interesting spot just to stop and see if there's any questions or commentary there.
Thank you, Nick. That was very interesting. Actually, certainly a few things that I didn't realise there. Can I ask a question? So most of our hospital-acquired and ventilator-associated pneumonias, are they from aspiration?
Yeah, I mean, I think if you look at all the things that we're implementing to decrease them, they're targeted at stopping the aspiration of oropharyngeal secretion. So cuff pressure, semi-recumbency, early extubation, getting people up in ICU. These are all things designed to A, decrease aspiration, B, improve the natural mucociliary clearance. So I think pathophysiologically, yes, that's what we're trying to prevent.
There's a few questions in the chat, maybe. One of them just is asking, is there a role for any other interventions in ventilated patients, such as bronchoscopic toilet, lavage, those sort of interventions?
Yeah, I think that's a really interesting question. I'm not sure. I mean, the only evidence I've reviewed on that is the old evidence for whether it worked for bronchiectatics, completely different cohort. The answer for that was no. But you know, I wonder. It's been a long time since I've put a bronch down in someone in ICU. But for me, it was always about getting that culture diagnosis. Is why we did that. But no, I'd have to take that one on notice. The second question there is so that's the continuous infusion rather than intermittent dosing. Yes, I mean, I think the pharmacokinetics of particularly continuous beta-lactam infusion, do tend to favour that, although there's not much in it. And it's one of those things in your career where it sort of keeps hitting the glass ceiling. It's there, the evidence seems to be there, but it doesn't sort of shift practice. So that's sort of where I see that issue at the moment. But notionally, yes, it is better.
Can I take from what you're saying to some degree that we should perhaps consider, especially from our general surgical, abdominal surgical cohort, that we should be changing our antibiotic surgical prophylaxis from cefazolin to something maybe more like a third generation cephalosporin or augmentin duofort as a practice point?
No, I'll be excommunicated as an ID physician. I don't think the evidence is there yet. I think what they're trying to do in ICU is for that critically ill post-surgical cohort, that broader spectrum gram-negative cover is something that we should be considering. Now, I had a couple of different conversations with different people. One intensivist, and I don't know if there's any neurosurgeons on the line, but one intensivist is very habituated to giving a single dose of ceftriaxone for any head injury or urgent neurosurgical patient that comes into their intensive care unit. So, I think this conversation is going to be coming up a lot more. So I think that comment there from Jody is important. What's the trade-off? So the Myberg study and the Hammond study were both very clear in saying that the use of the oral decontamination and the ceftriaxone did not put the selective pressure that they thought would happen for antimicrobial resistance. However, as I said, I called them and had a chat and said, well, why aren't we implementing this? And the reason they don't implement is exactly that, because people are still worried. I think the intensive care community in Australia works very closely with the ID community, and there's still too much of a concern. And that responds to your question, Phil. There's too much of a concern that you'll change the ecology and make things harder to treat. But I guess what I would take away as a practice point is this is an open question and it should still be researched, and we shouldn't be closing the door on this based on antimicrobial stewardship reasons alone. That's what I'd take away from it.
Thank you. Yeah. More to come, it sounds like, in this area. So thank you, Nick. Let's move on to our next speaker. Our next speaker is Dr. Ram Ganesalingam. Ram is a colorectal surgeon and general surgeon at Canberra Hospital, and he certainly played a key role in implementing ERAS programs here in Canberra, and has an ongoing role in multidisciplinary cancer care. And tonight he is presenting on ERAS. Thank you, Ram.
Can you hear me? Can you hear me? Yeah. Thanks, Phil. Thanks, and thanks everyone for tuning in. Thank you for giving me the opportunity to speak today. Going on with the theme of preventing hospital-acquired infections, I'll be speaking on the impacts that ERAS has on surgical infection rates. ERAS stands for Enhanced Recovery After Surgery. I was fortunate to be involved in the implementation of ERAS at the Canberra Hospital, and one of the earlier tasks of the process was to build awareness and promote the ideas. And so what better way to do that than to enlist the support of arguably the most famous person in the world. Next slide. Just in case anyone was confused, when Taylor Swift put out this poster promoting her tour, she was not promoting Enhanced Recovery After Surgery. She was, in fact, referring to the chronology of the various albums she's produced across her career. It was simply coincidence that her tour to Australia and our launch of the ERAS program at the Canberra Hospital happened around the same time. I believe there were some uninformed teenagers hanging around the Canberra hospital hoping to get a glimpse, which was never going to happen. But like Taylor Swift, enhanced recovery after surgery is on most hospital playlists. ERAS guides the perioperative approach at most major surgical centres worldwide. Conceptually, it has actually been around since the 1970s, described under various headings and different names, but has now become well recognised as a unified, evidence-based approach to pre, intra, and post-surgical care. Colorectal surgery, in particular, the major oncological procedures, was one of the first specialties to adopt this approach. Next slide. So what is enhanced recovery after surgery? Enhanced recovery after surgery is a multimodal, evidence-based perioperative care pathway designed to reduce the physiological stresses of surgery, optimize patient recovery, and shorten hospital stay. And doing all of this whilst without increasing complications or readmission rates. Basically, the objective is to return the patient to their pre-surgical physiology as quickly as possible after major surgery. The approach to achieving this is by breaking down the various aspects of perioperative care and improving them in small ways. The combined improvements producing a much better surgical outcome. Next slide. So what is marginal gains? Marginal gains is breaking down those components. This was the philosophy adopted by David Brailsford, who was appointed the director of British Cycling in 2003. David is actually the guy in the car, he's not the rider. Prior to his appointment, British Cycling had never won the Tour de France and had been awarded one gold medal at the Olympics for cycling. His concept of marginal gains meant breaking down everything that goes into riding a bike and then improving it by 1%. For example, he redesigned bike seats to make them more comfortable so people can train longer. He cleaned tires with alcohol for better grip, tested fabrics in wind tunnels and had their outdoor riders switch to indoor racing suits because they were lighter and more aerodynamic. He even hired a surgeon to teach the riders to wash their hands properly so they didn't get sick, so they didn't interrupt their training. 5 years later, 2008 Beijing Olympic Games, the Brits won 60% of all the gold medals in cycling. Next slide. So ERAS follows that similar approach. At the Canberra Hospital, we look to improve the various components of the pre, intra, and post-surgical care, introducing chlorhexidine wash to reduce the surface bacteria, carb loading and short fasting times to reduce catabolism prior to surgery, optimizing comorbidities, in particular glycemic control and COPD. In terms of the operative side of things, minimally invasive surgery. Smaller cuts means less infection exposure and faster recovery. Strict fluid and temperature control during the operation to minimize impacts on coagulation and immune response. Early mobilization, as Nick talked about, makes a big difference in terms of return to respiratory mechanics, as well as reducing risks of coagulation, DVTs, and pulmonary emboli. This early mobilization we introduced in coordination with physiotherapy, which requires a great deal of collaboration. Avoidance of drains if possible, but otherwise early removal of drains, lines, and catheters, and in particular central lines. Oral analgesia rather than intravenous or PCA, and then early return to oral diet to reduce the risks of ileus and the reliance on intravenous fluids. Most importantly, patient education around the above concepts and how they impact on recovery. We found that active participation by the patient towards their own recovery is an essential component to improving outcomes. What we found after 1 year of introducing these measures, the mean difference between the actual and predicted length of stay decreased by 4 days. length of stay reduced when comparing predicted versus actual. Long stays in hospital reduced from 20% to 6%. So that's patients staying over 2 weeks. The above improvements came without a significant compromise to their readmission rates. ICU admissions rates fell from 29% to 12%, with a similar drop in unplanned ICU admissions. Medical complications such as UTIs, DVTs, blood sugar derangements all reduced. Most significantly, there was a reduction in post-surgical infections, in particular, a drop in pneumonia rates. This table outlines the more common infections that we would find after major surgery. Surgical site infections, whether that's superficial or deep, occur in up to 5% of patients. And in the context of patients who undergo operations with contaminated wounds, this can be up to 20%. Atelectasis and pneumonia up to 15%, and even higher in those who require ICU support. Urinary tract infections, lines, drains, catheters, all sources of infection, and it can range up to 10%. Intra-abdominal infections, including anastomotic leaks, collections, hematomas, 5%. Prolonged antibiotic use and exposure to cephalosporins can inadvertently lead to Clostridium difficile infections and slow gut recovery. Thoracic empyemas, infection of grafts, implants, and prosthesis. These are less common, but if they do occur, can be catastrophic. So what does ERAS do? It aims to minimize the potential for acquiring these diseases by implementing measures that puts the patient in a better position to either fight infections or reduce their exposure altogether. So glycemic control, skin preparation, normothermia, reduce rates of surgical site infections. Early mobilization, incentive spirometry, chest physiotherapy, reduce atelectasis and the potential for chest infections. Avoidance or timely removal of lines and drains, and preferably avoiding them altogether, minimize the routes to acquire some of these infections. And then carefully considered antibiotics to avoid unintended consequences such as C. diff and slow gut recovery. So that's the basis for which enhanced recovery aims to reduce the exposure of patients to some of these very common surgical site infections and post-surgical infections. So if we look at pneumonia as an example, ERAS reduces post-operative pneumonia by combining several complementary measures. Optimization of comorbidities, in particular blood sugars and COPD. Pre-op assessment, flagging patients that are physically and nutritionally depleted prior to surgery and giving them the opportunity to improve surgical fitness. And that often means referrals early to physiotherapy and dietitians, just to optimize the patient in preparation for the major operation. Early mobilization and timely removal of lines and drains improves respiratory mechanics, particularly after thoracic surgery. Multimodal analgesia, and that works in close collaboration with anesthetics, including spinal anesthetics, regional blocks, provides a far easier respiratory recovery rather than relying on intravenous or PCAs. Avoidance of opiates in general is going to reduce your risk and improve the chances of avoiding or making respiratory mechanics more difficult. Ultimately, the flow-on effect of those measures leads to a significant reduction in ICU admissions. We know from the EPIC-2 study that ICU admission itself is an independent risk factor for pneumonia, especially hospital-acquired and ventilator-associated pneumonia. Looking at our own data from TCH, before ERAS, we had 29% of our patients required ICU support. After ERAS, that dropped to 12%. That coincided with a similar drop in post-surgical pneumonia from 5% in the past, and we actually reduced that to 0 cases across the year in the patients that were implementing this ERAS program. So overall, the evidence, as well as our own experience, strongly suggests that ERAS measures not only shorten ICU stays, but also play a role in significantly reducing the postoperative risk of pneumonia after major surgery. The majority of data around ERAS is based around colorectal surgery. ERAS has since widened its reach to offer benefits to other surgical specialties. In any case, the key cross-specialty themes for infection reduction via ERAS remains relatively standard. Shortened fasting times and early nutrition, normothermia and oxygenation, early mobilization, reduced opiate use, and early removal of lines and drains, all of which aim to reduce surgical site infections, reduce the risk of pneumonia, reduce medical complications such as urinary tract infections, and in particular for the orthopods and the vascular surgeons, reduce the risks of graft infections or implants, prosthesis infections. Implementing ERAS pathway in a new hospital brings with it a number of challenges. First, there's the issue of cultural change and management. ERAS requires a shift from traditional perioperative practices to a standardized evidence-based model. This often means convincing surgeons, anaesthetists, allied health staff to change long-established habits. Multidisciplinary and coordination is one of the cornerstones of ERAS, and that means that all the working groups, their objectives, their goals, their long-term strategy for patient care, they all have to align. Without that collaboration, it's too easy for pathways to break apart and people start doing individual treatment strategies that don't necessarily coordinate and ultimately lead to the best outcome. Resources. Implementing an approach like this does require resources. Not every hospital has immediate access to dietitians, physiotherapists, specialized equipment, incentive spirometry, warming equipment. So certainly there needs to be some funding and certainly some administrative support. Education and compliance staff need to be trained and then often retrained, and then compliance has to be monitored closely to ensure that pathways are actually being followed. Compliance measures are one of the key components, and certainly identifying early on in the course why compliance isn't meeting the required mark. Data collection and audit, that's critical for the design of an ERAS protocol, most effective when outcomes are measured, because it means that feedback can be given to the various teams. It can then be used to refine the protocol specific to the resources available to each specific individual centre. So in summary, enhanced recovery after surgery, or ERAS, is essentially a collaborative multimodal care pathway that optimizes perioperative parameters to improve recovery after major surgery. The benefits are well established. Patients recover faster, complication rates are lower, and we see significant reduction in infections such as surgical site infections, pneumonia, urinary tract infections, and prosthesis and vascular rates of infection. Grafts. Length of stay is shortened, and importantly, by reducing ICU admissions, which I think is one of the key aspects of minimizing surgical complications, we also lower the risk of post-surgical pneumonia. But while the outcomes are great, implementing ERAS is not without its challenges. It requires collaboration, it requires funding, it requires IT support, but most importantly, it requires clinicians and staff to look at the way they practice and start to think of collaborating and aligning their practices in a coordinated manner with the other team members that are involved in a particular patient's care. ERAS is both a clinical and cultural change, and one that pays off, and certainly that's what we found with our initial data. And I think we're very, very proud of what we've achieved so far. Obviously, we're now expanding the ERAS protocols into other specialty areas at the Canberra Hospital, and that includes vascular, neurosurgery, maxillofacial, and urology, and even gynecology. And were one of the first groups that started with us in colorectal surgery. But that's the data that we've got at the Canberra Hospital, and that's how our exposure to ERAS has led us to this point. I'm happy to take some questions.
Thanks, Ram. That's a great presentation. Maybe we could just start with, what is your experience about the actual time that it takes to implement this? How long did it actually take, and what were some of the greatest hurdles you encountered?
I think it took us about 2.5 years just to sort of talk to the various specialties, come up with the design, get backing from the hospital, funding, as well as administrative support. You need a champion, which is often a number of surgical colleagues and anaesthetic colleagues, and then we had to employ a specific nurse to coordinate a lot of the data collection and implementation, getting the feedback from the nurses. So it is a big task to implement something like this in a tertiary centre. But to start with, we started with 2 teams. That was colorectal and gynecology, and that was a manageable area to start because the teams weren't huge, the numbers weren't huge, and it gave us the opportunity to iron out some of the shortcomings in the protocol. And then once we were happy with the way things were moving, we then expanded that to more specialties. Certainly with the initial results, the feedback from the teams were very positive, and certainly administrative. The administration looked at the numbers and were very supportive. Within the first year, the numbers looked very good, and therefore they provided funding for the following 5 years.
Thanks. I wouldn't say I'm a Swiftie as such, but I tend to remember her tour was just a couple of years ago. So in that data, you've got some great data there over 2 years. What pathways do you have in place to sort of ensure that the fidelity of the process continues rather than some sort of implementation effect?
Yeah. I mean, the evidence would suggest that there is always that initial phase where everyone's on board, everyone sticks to the program, everyone that we've trained remain with the protocols. However, the data does say that after the second year, things can change. Personnel change, nursing staff change, need retraining, and that initial excitement of the whole implementation does wear down. We're waiting to see how that goes. There's certainly initial signs that we will need to retrain some of the staff. A lot of the surgical measures are fairly standard, especially in colorectal surgery. It's generally a minimally invasive approach for the majority of operations, and anaesthetics have certainly supported us with spinal anaesthesia. And so, we are collecting that data. We are expecting that the numbers will change and may sort of come down in the next few years, and that's something that ERAS is certainly geared to do. The way we've structured it, the data's collected in real time, which gives us the opportunity to identify the areas of weakness early on and then try and address them as soon as we can.
Just on that data, how you're decreasing length of stay in colorectal quite considerably, and presumably similar effects are seen in the other surgical groups. Do you collect data to ensure that you're not just transferring hospital-associated infections to the community or outcomes to the community?
We don't believe so. There's certainly not much in that area in the literature. Most of the time, infections occur while they're in hospital. Most of the time, the readmission rates are not associated with infection. In our data, it'll be mostly post-operative pain. Sometimes wound infections do manifest in the subsequent week after discharge. But no, we don't believe that there is a significant increase in transmission into the community. I think most of the patients that leave hospital are well enough to do so, and are able to be followed up by the general GPs in the community.
Is there any data on other outcomes such as oncological or survival or long-term outcomes and differences with ERAS and traditional surgical pathways?
Yeah, no, we don't have, well, there is data, and it doesn't indicate that there's a negative impact on oncological outcomes. Certainly the more significant factor is the readmission rates and the complication rates, and the question is, are we sending patients home too early? Certainly with a well-coordinated ERAS protocol, as well as good follow-up care, that number doesn't appear to be one that goes up too high. We did have a slight increase in readmission rates, but it certainly wasn't a big number.
There's also, I think, a very good question in the chat here. It sort of is in respect to other hospitals implementing ERAS pathways. Given that this is, there's a lot of hospitals that have established these ERAS pathways, is there any support for hospitals that are trying to do this instead of every hospital reinventing the ERAS wheel, so to speak? Is there any college supported, or are there any groups that actually help other institutions?
Yeah, there are ERAS society. There's an ERAS society that generally does put out a lot of the data that instructs how to tailor an ERAS protocol. Unfortunately, that every hospital is different, and certainly there's hospitals that I've trained at and exposed to, and when we researched on our pathway to making this, it is very hospital specific, and you do have to tailor certain things to allow for the resources that are available. The fundamental principles are still the same, however, and if you go back to those key components are able to be achieved by most tertiary hospitals. It does require, however, a certain amount of planning and coordination amongst the various specialties, and that's not just anesthetics, but also the nursing staff, physiotherapists, dietitians, and pharmacy. So if that collaboration is able to be created, then most ERAS protocols can be successful, but it is very much a hospital-specific a setup process.
Approximately 10 minutes.
So I've just got an alarm going here. But so would you say the ERAS Society might be a good point of call for anyone trying to implement it?
Sorry, I can't hear that one. Say that again, Phil.
Sorry, it was just an alarm going off at the office here. So I was just, as a first point of call for anyone trying to sort of start this process in a hospital, would the ERAS Society be a good starting point for them in terms of generating the core aspects of their policy development and those.
Yes. Yeah, I think there's a lot of data out there, but ERAS Society does produce a lot of the publications. They're responsible for scouring the literature to identify any new studies and any data out there. They collate it all together to make it an easy place to find what you're looking for, and then the rest of it is really out there in the literature. There is plenty of studies to support ERAS in various different specialties, and I think if you did want to go about creating one, there are plenty of resources available, but certainly the ERAS Society is probably the first place to start.
Thank you, Ram. I think we probably a good time to thank you for that presentation and move on to our next speaker. The next speaker is Dave Turner. Dave is an exercise physiologist at Canberra Hospital and manages the prehabilitation service here, and he is going to discuss the role of prehabilitation.
Thank you very much for having me tonight. If we go next slide. Thank you. So Ram's talked us through ERAS, which covers this whole range from referral through to follow-up. And ultimately what we know as a successful surgery is that that patient can recover to their physical and psychological level at that baseline. And we know that there is going to be a dip when surgery occurs. What we're looking at with prehabilitation is specifically in the optimisation, so that red section there. There are some prehabilitation services that will get involved earlier, especially in some of the like orthopedic areas where prehabilitation can actually deem that surgery is not required. For example, knees and hips, there's a bit of work there, but specifically for today, I'm going to talk about optimization. So the decision has been made that surgery is being undertaken, and we're looking to see what we can do in that space in the lead up to surgery to get some positive outcomes. Next slide, thanks. So what we're looking at is the concept of prehabilitation in graphic form. So ultimately, we know that there's a period of time where a person is set for surgery, and then we're following that curve of preloading them with stress across that prehabilitation or that shaded section. So the main areas that we're trying to do is provide a physiological stress to see some improvements in their aerobic system, also in the strength and their functional abilities, and that comes from specific exercises that are provided for the muscles of the body as well as for the respiratory muscles, and there are also some nutritional components involved. When surgery occurs, we do know that major surgery can have a significant decline in functional ability, so you'll see that near vertical line. What we're hoping is that by having preloaded those individuals, we're looking to be able to see that faster recovery line, and also for individuals that are having a complicated recovery, getting them back above that line of dependency. When we're looking at prehabilitation, it is not for every patient. We're looking at the high value. So you're looking at your frail patients, oncology, BMI changes, adjuvant therapies. I'll go on to a few more factors as we go through. So ultimately, it's preloading sees that improved recovery in functional outcomes. Next slide, please. So the Canberra Hospital provides a prehabilitation service, and it focuses on NEW. Everything in health has to have an acronym, so ours is NEW. It's nutrition, exercise, and well-being. And based on the meta-analyses, the exercise and nutrition components are the most critical in an effective prehabilitation service, so they are prioritised. And then where there are individuals where we note that there's excess likelihood of stress and anxiety leading to concerns for recovery or cancellation rates of surgery, we're also looking to get some supports implemented early for those individuals. Next slide, please. When we're looking at the literature, it is quite a heterogeneous, I suppose, past few decades. So we can go to some of the individual studies and also the meta-analyses, but there really are some quite variable models that you are trying to compare between. When we're looking at prehabilitation as a general concept, it's usually looking at up to 12 weeks before surgery. The evidence suggests that if your time frame is outside of that, the results generally aren't going to be as strong. It's generally that 6 to 12 weeks, noting that within the Canberra Hospital, most of our referral pathways are coming between 2 to 5 weeks out. You can still get some benefits in your intervention when you're looking within 2 weeks. However, we just do expect that spectrum of therapy being able to be provided and then the outcomes to be achieved are impacted, but you still can get some positive impacts. I'm going to talk us through a couple of different studies. Yep, next slide, thanks. So the first study is looking at a reasonably low intensive form of prehabilitation where it's an allied health physiotherapist that's providing one appointment prior to surgery on deep breathing, on the risks of post-pulmonary complications and the benefits and what is going to be expected of them with early ambulation, and then post-operative to reinforce that they are complying with what's been educated and that there's no challenges that have occurred that's meant that can't be followed through. So even with this, what we would describe as low intensity version of prehabilitation, the outcomes are that there's a 33% likelihood to develop a post-pulmonary complication, and the number needed to treat of 8. This is an extremely cost-effective measure, with a length of stay reduction of a reasonably small 1 day. But again, this is a low intensity, but still positive outcomes. If we go to the next slide, we'll talk about a few more of the components that can be added in to get some additional benefits. We're looking at roughly the past 2 decades. There's plenty more studies than this, but this is looking at preoperative exercise. The studies included are focused on predominantly aerobic exercise, resistance exercise, and or inspiratory muscle or respiratory muscle training. What we found about 2 decades ago is that the research was being quite gently looked into in terms of the exclusion criteria were quite large, the intervention intensities were quite low, and as we've come further and that feasibility and safety has been proven, the results are starting to improve as we're getting the right patients and the right interventions. So what we're looking at is that exercise training is better than control when it comes to risk ratios for post-op pulmonary complications. Next slide, please. So when we look at that meta-analysis, we're looking at the complication rate. So the preoperative exercise group brings our complication rate down from 32.4% to 17.7%, with a relative risk ratio of 0.52, lowering risks of pneumonia, 0.72 risk ratio, and closer to what you would expect to see in a full prehabilitation service at that sort of negative 2.3 days, so reducing length of stay. When you're adding additional modalities, when you get a little bit more of the right patient selection and a little bit more intensity and time to complete that volume of therapy, we can see better outcomes as well. But that's good to see that that's where that baseline is. Next slide, please. So I've mentioned value a few times. We know that for major surgery, for non-cardiac surgery, complication rates can be quite high. Different areas will include different complication factors in that, but we know that prehabilitation is cost effective when it comes to the right person. So that frail patient, when the intervention has sufficient intensity and time to take course, when we're looking at the right outcome metrics, again, some of the studies had previously had quite a bit of variability in their reporting. There are now standardized measures through the COMET process, and cost effectiveness I'll touch on again in a moment. Next slide, please. Within our service, we use the MDASI-4Q as one of our screening tools, which is a functional impairment assessment. And it's a modified version of what's recommended by the College of Anaesthetists as a screening measure. It's 4 questions you can see on the right-hand side. So asking the patient directly, are they able to climb a flight of stairs or walk up a hill? Do heavy work around the house? Do yard work or participate in strenuous sports? Yes, no responses, and less than or equal to 2 is an increased risk of post-operative complications, and that aligns with cardiopulmonary exercise testing data for anaerobic thresholds and VO2 peaks. It's a really quick and easy way to get an objective assessment of patients. Now, that's not every patient going through a surgery pathway. We do have that relative to the ERAS specific surgeries and some additional criteria, but that's a bit of a basis of where you can understand patients are going to be eligible for the service and coming in. Another way, or a reasonably simple metric, is a distance of less than 400 meters increases risk of complications in gastrosurgery. And when you're getting below about 220, 230 meters, that is very substantial risks. And some patients at that level will actually have surgery postponed to see whether there is a chance to enhance their functionality in the lead up. Next slide, please. So my take-home messages, we really want to make sure that that success from surgery starts from referral and goes all the way through till they are back home and recovering. And part of that is a bit of a language and a mindset and that culture change. We want people feeling enabled, and we want some terminology shift in terms of waiting list to preparation list so that they're taking control of their health. We recommend taking advantage of reducing your surgical complication rates and that doing nothing can cause harm. It's the patient who's frail, crumbly, or that you think needs to be wrapped up in cotton wool. These are often the people that have the most to benefit from prehabilitation, so I do encourage you not to rule them out too early. Establish screening and referral processes and work as a team, and then keep up to date with the evidence base. So again, that choice of patient matters, the intervention matters, and personally I'm quite excited that there's an Australian costing study due for publication later this year. Internationally and some other smaller projects, you're generally looking at about a return of investment of 4 to 1, noting that pulmonary complications cost about $29,000 in Australia. So part of the savings come from length of stay, bed savings, and then what this study does, which is quite novel, is also looking at the consumables for individuals that have post-operative complications and how some of those consumables are actually more expensive, so that if you do have those bean counters in the hospital that say, even if you're saving bed days, we're just going to put someone else in the bed anyway, some of those consumable costs really add up. So I've seen some of the unpublished data and it's looking quite positive. Next and final slide, thanks. So I've got a bit of a consumer feedback example up on the page there that you can read through at your own time, but this is from a patient that I suppose benefited more from the prehabilitation than they initially thought, and it was nice to see both the physical and the psychological elements go through for them, and I'm more than happy to take any questions.
Thanks, Dave. That's certainly, I agree that prehabilitation is an underutilized resource, and I like your idea of preparation list. Are there any questions for Dave?
So so Dave, in terms of patients getting selected for prehab in Canberra Hospital, who flags these patients for prehab?
Sorry if there's a little bit of background noise. So there's a couple of different referral pathways. So the ERAS nurse and the pre-admissions clinic certainly play a role, and they're one of our, I suppose, common referral pathways. We also get quite a few referrals coming through from our cancer specialist nurses, especially as some of the patients are getting their adjuvant therapy, and then we're hopefully actually able to get more than that sort of 2 to 4 weeks. We might get closer to that sort of 6 to 8 or possibly even more weeks of therapy time. They're our two biggest, I suppose, referral pathways.
So do you have any particular criteria that you choose these patients, or you just do everyone who's been referred?
I suppose that's probably a longer question in terms of resource capacity. We do go off some of the literature that describes the impacts are best suited when major surgery is greater than 3 hours as a minimum, greater than 5 hours as the recommended. For our MDASI 4Q, we will only take people that are at increased risk. And then I suppose we do have some additional criteria in terms of the exact surgery and some of the access in terms of our remote and regional patients versus our local patients. But yeah, there's some criteria there.
And with your MDASI questionnaire, is there something that's catered to older patients? Because strenuous sports, I'm not that old, but I don't play any strenuous sports. Probably I might fail. Is there a modified version for elderly patients?
So the main cohort for these questionnaires was an older population. So it was developed at Peter Mac Hospital. So that, I suppose, oncology and more aged population group. It's that they have the ability or the capacity to complete that activity. So, for example, we might get some people say, I don't walk upstairs, but I could. And that might be that we'd say, okay, they're okay with that answer, but in terms of doing yard work, that's where they might say, no, I'm not capable. There are longer questionnaires. So again, we've just used the simplified version for patient ease and timeliness of referral, and for some of our referring clinicians that are doing the screening. But ultimately, it's lining up with, I suppose, the risk profile from cardiopulmonary exercise testing, which Canberra Health Services doesn't particularly do. It's done quite widely in some hospital networks elsewhere, but I suppose that's where the data is coming from.
Dave, question in the chat. I think this is relevant for what our ideals would be for oncological surgery. What would you mentioned a little bit about the minimum time frame you'd want for prehabilitation. What would you say is that minimum time frame, given that often our oncological targets for patients are to operate on them within 28 days? Does that fit a prehabilitation model?
Yeah, again, for the high risk patients, absolutely. There's some of the logistics in terms of, we find out that they're for surgery at 28 days. That means 2 days later, a referral might get put in. It's the weekend. Our staff triage it, try and book them in, get them in a few days later. All of a sudden, you are losing valuable days. But especially for those high risk patients, 2 weeks can be sufficient to see a meaningful and significant change in their clinical outcomes and their recovery. Again, it's that sort of less than 2 weeks where you need to understand what it specifically is that we might be able to have an impact with. And there are some interventions which are better suited to short time frames. And also when we're seeing several different streams of surgical groupings coming through, we will tailor things slightly depending on what the surgery is. So for example, our vascular patients will be focused a little bit more on an aerobic therapy. For some of our frail oncology patients, if we only have 2 weeks, we're really going to try and focus on some of the functional movements that, as you can sort of see in the consumer feedback there, that is going to enable them to participate in some of those additional ERAS measures, like early mobilisation, that otherwise wouldn't have been capable. But yeah, ideally, we kind of look at, 6 weeks is more ideal, but yeah, 2 weeks and more, we can do it. Less than that, it depends on what their base situation is.
Thanks. I agree. I'm a big proponent of prehab as well. And I think that I'm not sure if you are doing this at Canberra Hospital yet, but there's also the concept of you're prehabilitating them for their adjuvant chemotherapy as well. And there's certainly good data to say that prehabilitation improves completion of chemotherapy regimes. And so you can prehab them through their surgery, actually, for their adjuvant care. Are you... what psychosocial interventions are you focused just on the physical aspects, or are you also involved in the nutritional or psychosocial interventions that might be available for prehabilitation?
So where possible, we try and align some of our services to make it work for the patient, so that, for example, they're coming in and they're getting multiple supports in one visit. But the specific nutritional component will come from our dietitian colleagues. The main focus is increasing protein intake in the lead up to surgery. In terms of the psychosocial or the wellness and well-being, the intention was that social work would be providing some tailored care. Unfortunately, that was logistically a bit of a challenge to get happening. But even from, I suppose, the patient that's not at particular risk of psychosocial concerns, the support that they've received in terms of the endorphins whilst they've been coming in, they've been having contact with regular health professionals, and some of the ERAS education booklets have made some positive changes, and we've seen that in the feedback responses. There have also been some patients where we've noted that their level of anxiety about surgery, for various reasons, is quite substantial, and so we've actually been able to get some support from psychology and social work to try and get involved early to both make sure that the patient is able to, first of all, keep their surgery date and stay within their surgical process, but also have a reduction in that sort of heightened response and feel more comfortable for their situation. It's just less standard getting some of the social work and psychology input.
Thank you. Maybe just a brief question. Is there any of this work happening in the private sector? That can be a question to the other surgeons on the panel as well.
I don't think so. Not that I'm aware of.
Private sector, I don't have as much information. I know that in bariatrics, that's an area where prehabilitation is supported, I suppose, in certain private settings across Australia and internationally. In terms of some of the other areas or surgical streams, it's more of a public health led system.
Thank you. Well, I think we are over time, and I think that is partly because these presentations have generated a lot of discussion, a lot of questions. I think we should then wrap up. I'd like to thank the speakers, Dr. Nick Coatsworth, Ram Ganesalingam, and Dave Turner. Once again, Siva Gananadha for his ongoing work at the ACTASM, and of course, Ebony and Emily Rose for their support behind the scenes tonight and ongoing. And thank you to all the participants. There were a lot of people online tonight, which I think is always great to see. Siva, would you like to have any closing words?
Yeah, I echo whatever you said. Phil, thanks a lot. It's been a fantastic evening, good discussion. Lots of avenues to improve outcomes. Prevention obviously is better than cure, so there's a lot of food for thought. This could be enough to help fund, better prehab and ERAS pathways. There's significant health savings on the long term. So hopefully we can take this back to our hospital. Thanks a lot, guys. Thanks, and thanks, Phil, for sharing. Thank you. All right.
Thank you. Evening.